Hello, my name is Asia Takeuchi, and I will be taking you through the fundamentals of emergency ultrasound. The focus of this lecture is to discuss the basic utility of ultrasound in the emergency department, the physics of ultrasound, and to make you familiar with our machines and documentation process. I recognize this may not be the most exciting lecture you've had, so caffeinate up, ramp this up to 1.5 speed, and we will be done before you know it. Let's start with why we think ultrasound is an important part of our practice. It is an invaluable tool for resuscitation. It is immediately at our disposal and not subject to delays of radiology availability. It is often more cost-effective than other studies. It certainly affords less radiation to the patient, and perhaps most surprisingly, patients really like it. All of that said, it is important to be mindful of our limitations as well. Remember, we are doing limited exams to help answer a specific clinical question. This is not a formal radiology study, and as with all skills, you should be mindful of your own level of experience and do what is best for the patient. So how does ultrasound work? At the most basic level, ultrasound is the propagation of a series of sound waves through a medium. Any echoed signal that bounces back to the source of those sound waves is used to create an interpretation of its surroundings. When it comes to the technological application of ultrasound, we rely on the piezoelectric effect. Here, an electric current is applied to a set of crystals within the transducer, causing vibration. The vibration of the crystals produce sound waves that travel outward. Conversely, when sound or pressure waves return back and hit the crystals, they vibrate again, resulting in an electrical current that the machine is able to interpret into a visual representation on the screen. We will now, just briefly, dig a little deeper into the physics of these sound waves. The two terms you will hear frequently mentioned in ultrasound is frequency and echogenicity. Frequency is either described as low or high and refers to the number of cycles per second, or hertz, emitted by the transducer. The frequency of the probe you select will affect the depth, penetration, and resolution of your image. Echogenicity is an effect of amplitude, or intensity of returned energy, that the machine receives. When we describe how echogenic an image is, we will use the following terms. Hyperechoic, the area of interest is brighter than its surroundings. Hypoechoic, the area of interest is darker than its surroundings. Isoechoic, the area of interest appears the same as its surroundings. And anechoic, which describes the complete black appearance or absence of signal altogether. You should also be aware of attenuation and how different components may affect the study you are performing. We will talk about these in a little more detail over the next couple of slides. Absorption is the conversion of acoustic energy into heat. This is where the ALARA principle comes into effect. That is to say that ultrasound exposure should be as low as reasonably achievable because the potential for tissue heating when the thermal index exceeds 1. Exposure can be reduced through the use of output control and/or by reducing the amount of time the beam is focused in one place. Scatter occurs when the sound waves encounter a medium with a non-homogeneous surface, causing a portion of it to scatter in random directions. This is particularly obvious when imaging the pleura or bowel, as they are typically filled with air. Reflection is obviously largely what we rely on to interpret tissue boundaries. The amount of wave that bounces back towards the source has to do with the difference in acoustic impedance at that interface. The degree of mismatch at the interface determines the extent to which signal is reflected or transmitted. Based on the different acoustic impedances of the tissue that make up the body, we generally expect anechoic signal to represent fluid-filled areas, bone or calcium-dense material to appear hyperechoic, and most soft tissue to fall somewhere in between. Refraction occurs when a sound wave travels through a second medium or tissue but is bent from its path. This is an important concept for two reasons. The first, it accounts for an artifact we will discuss later called a mirror artifact. The second is probes are typically modified with an embedded acoustic lens that uses this phenomena to create an ideal focal point and improve image resolution. Lastly, and probably most intuitive, is the idea of diffraction. Basically, attenuation is increased and hence penetration of the beam reduced as the distance traveled from the transducer increases. I'm sure you're asking yourself at this point, why does any of this matter? Just remember, having a basic awareness of these concepts will help guide how you perform your studies, help you to select the best transducer for your studies, and hopefully optimize the information you gleaned from them. Okay, if you've made it this far, I promise the rest of it will be more interesting. Stretch a bit, get a coffee refill, and we move on to more practical, hands-on concepts. These are the four most common transducers you are likely to see in the ER. The endocavitary probe is most commonly used as part of the pelvic exam, but I would discourage you from calling it the endovaginal probe in front of patients, as it can also be used orally to evaluate for peritonsillar abscess. The curvilinear probe is in most ways similar to a phased array probe but has a larger footprint. This can be useful when evaluating larger patients or trying to displace bowel, but can make it difficult to fit between rib spaces. The linear probe is a high-frequency probe better for evaluation of shallow structures such as soft tissue, ocular, and peripheral vascular structures. The phased array is a low-frequency probe good for depth penetration. It is our go-to probe for cardiac and abdominal exams. A few public service announcements about the probe. 1. Please keep them clean. Wipe them down after and even before each use with Sanicloth wipes. You should also be using new individual gel packs for each patient if available. 2. Please be gentle with the equipment. These things are expensive and somewhat painful to replace. Please be mindful of cords. They are easy to run over. Also, any drops, chips, or cracks in the probes themselves can easily displace the crystals inside. 3. You will have the best dexterity with the probe if you hold it at the end closest to the patient and use your free fingers or edge of palm to stabilize and anchor your hand. Think of using it exactly how you would use a pen to write on paper. As a general practice, you will want to orient the probe with the marker dot pointed either towards the patient's head or towards the patient's right. This will correspond to the index marker on the left side of the screen. There are some exceptions to this, such as the orientation for the cardiac exam and procedural orientation that will be discussed further in other lectures. When giving direction about how to manipulate the probe, we will generally use these terms. When fanning, you sweep through an organ, moving perpendicular to the marker dot, almost like flipping through the pages of a book. When rocking, you will be able to centralize the image on the screen by swaying either towards or away from the marker dot. Rotational movement is like moving around the axis of a clock, and sliding is a simple gliding movement either up or down or side to side. When doing an ultrasound study, you will always want to examine the area of interest in 2 dimensions, both short and long axis. When orienting the probe in the transverse axis, the marker dot will be pointed towards the patient's right, with the proximal part of the screen responding to the area closest to the probe, in this case the patient's belly. The deeper or more distal portion of the screen corresponds to the patient's back. In the sagittal axis, the marker dot is oriented towards the patient's head, again with the proximal part of the screen corresponding to the patient's belly and more distally to the patient's back. Finally, in the coronal axis, the marker dot remains oriented towards the patient's head, with the proximal part of the screen corresponding to the lateral surface of the body and the dependent portion of the screen corresponding to the medial plane of the body. All right, we're halfway there. Let's move on to knobs and buttons. Currently, both departments are staffed with Zonare machines. When setting up the machine, you will use the transducer button to select the probe you want. This is followed by the exam preset. The next 4 buttons correspond to the different modes of ultrasound. At the far right is the B button. This corresponds to the brightness mode and can be used to adjust the shades of gray as they appear on the screen. You will notice a purplish button in the center of the screen labeled Optimize.
This works similar to the autofocus on a camera and should be used whenever you switch presets or adjust depth. As you can see, too much gain will cause excess hyperechoic signal, whereas too little gain makes the image appear excessively anechoic. M mode, or motion mode, captures returning echoes in only one crystal line on the B mode image, but displays them over a time axis. Movement of structures positioned in that line can now be visualized. Often, M mode and B mode are displayed together on the ultrasound monitor. This mode can be useful when assessing lung sliding, fetal heart rate, and contraction of both cardiac and vascular structures. The C button refers to color flow. This is used to display directionality and velocity of flow in a color code. Red represents movement towards the probe, while blue is moving away from the probe. The intensity of color reflects velocity of flow. An easy acronym to remember is BART, or blue away, red towards. The last of the modes we will discuss is Doppler mode, represented by the D button. This mode creates a continuous impulsed waveform that displays the spectrum of returned Doppler frequencies both audibly over the speaker of the machine as well as in a 2D image. In the ER, we most commonly use this to help differentiate between venous and arterial vascular flows. Remember to optimize your real estate, as the probes are designed to have an ideal focal point. To do this, you will want to use the depth knob to make sure your area of interest is in the middle of the screen, while using the minimal depth necessary. Here you will see an example of an excessively deep view of the femoral artery and nerve. Conversely, if you were too shallow, you could miss the deep structures altogether and accidentally focus on superficial vasculature. The example on the right is perfect. The last few buttons you will want to become familiar with are those in the two arches surrounding the trackball. We will spend direct hands-on time showing you how to use them. Just be aware the trackball will operate like a computer mouse or cursor, and the other buttons will basically allow you to save and manipulate the images on the screen. If you've made it this far, we are in the home stretch. Artifacts are the last part of ultrasound physics we will be discussing. They are important to be aware of because they have the potential to lead to misinterpretation. However, with the information we just reviewed, you will be better able to understand these phenomena and use your knowledge to improve your clinical acumen. Acoustic shadowing is actually an artifact we use frequently to help us identify particularly reflective material, such as bone or various types of stones. Here, at least some portion of the acoustic signal is unable to pass through the object of interest. This appears as a deep shadow throughout the dependent portion of the screen. Acoustic enhancement can almost be thought of as the opposite. Here, there is no return of sound waves as they travel through a fluid medium. It isn't until they slam into the wall deep to the fluid collection that they send back an enhanced acoustic signal. We frequently see this when looking at the gallbladder or urinary bladder. Reverberation artifact is basically a repeat reflection of an image that can typically be eliminated by changing the angle of the transducer. I've seen this over neonatal vertebrae, but perhaps more clinically significant, it can sometimes be used to identify retained foreign bodies, especially metal ones. Edge artifact will often look like anechoic rays off the edge of a curved structure. Do not be fooled into thinking this is abnormal fluid. Really, it is just a form of refraction. Last is mirror artifact. This occurs when a strong acoustic reflector, such as the diaphragm, causes additional sound waves to be bent towards the neighboring anatomy. These bent sound waves will make any object in front of the reflector, like a liver cyst, falsely appear duplicated on the opposite side. We actually use this as a normal sign when performing our extended fast views. That's it for physics. Now we will briefly go over documentation. With each study, you will want to make sure you start by recording the patient's information. To do this, you will tap the button on the upper left corner labeled New Patient. You will need to type in the patient's name and MRN number. Please enter your last name in the operator section and the name of your supervising attending in the referring physician box. Under Study Design, please enter the type of study you are performing and in the comment box a brief description of why you are performing the study. You will then want to hit the Save button next to the trackball to store the patient's information before you continue on scanning. Once the scanning is complete, push the New Patient button again. This should bring up the screen you already saved. You will now want to put the interpretation into the comment section and save again before exiting the study completely. Please note it is best to avoid using your initials when recording the operating physician because we track your study numbers using your last name. Once the studies have been saved on the machine, they should be wirelessly uploaded to our electronic image program Impacts. To find your study, simply search for the patient's name. Note the studies performed in the ED will not have an ACC number or requesting procedure type, and the study description will reflect whatever you entered into the ultrasound machine. While these studies are discoverable by anyone in the hospital, they are not read by radiology. Rather, they are reviewed by our ultrasound division, and a legal teaching disclaimer is attached to each study. You should never hesitate to perform a study in the department, whether that is with your senior resident or attending. However, please be aware that while many of our attendings are ultrasound certified, not everyone is, and they may choose not to use the study as part of their documented decision making. There is no need to memorize this list, as there are likely some others who need to be added. Please just ask whomever you are working with if they will review the study and if they want to document their findings in the chart. Chart documentation is quite easy. Simply use the dot phrase EDUS. This will bring up a pre-formatted study template, and you just need to use the F2 button to tab through each selection. Once a template has been selected, it will walk you through each section that needs to be documented. Please remember to document an attending with whom you are performing the study. Occasionally, an ultrasound certified attending will help you with the study for a patient you are staffing with a different attending. With that, one last word on housekeeping issues. Please remember to fully close out each study once you have finished so that patient information isn't left up on the screen. When not in use, please remember to plug in the machines. It's always handy to have a fully charged battery when you are grabbing the machine for a critical patient and not having to worry about plugging it in because of a dead battery. Congratulations, you've made it to the end of the lecture. While a bit dry, I hope you understand how this lecture will help you optimize your ultrasound skills and to aid in your clinical decision making. While the concepts and spatial orientation can be difficult at first, I promise it will become second nature with practice. Thank you for sticking in there. Please bring any questions you may have to our hands-on lecture at orientation. See you soon.